So let's talk about small cell lung cancer. Now, I am Dr. Roman, and I'm a blood and cancer doctor. And whether you are a healthcare professional that simply wants to learn about small cell lung cancer, or more importantly, if you're a patient or a family member, I promise you this video will be worth your while because I'm going to cover everything that you need to know so that when you go see your doctor, you are not blind. I mean, you want to go into this appointment prepared. You want to know what questions to ask, and you want to have a good idea as to what they are going to talk to you about. Now, with that being said, I will cover a lot of information. I mean, this is a pretty comprehensive video, but this is what you need to know. If you try to watch a video that is shorter or does not cover so much information or is a little less complicated, then guess what? You are not going to be fully prepared. And I promise you, well, at some slides you may feel a little lost. I'm going to be a little repetitive in a follow-up slide, so it might make sense to you in the next few slides. So tough it out, and I promise you, you will learn a ton. So with that being said, let's get started here. Now, as with all my videos, this is for educational purposes only. I am not providing medical advice. Now, let's go over an overview of what we're going to cover. So we're going to talk about the different types of lung cancer. Then we're going to talk about small cell lung cancer per se, just some details that I think you need to know. We will also talk about symptoms, the staging of small cell lung cancer, also the different treatment options. Now, throughout this presentation, I'm going to be going over questions that I would ask if I had small cell lung cancer. So think about that. I am a practicing physician. I mean, I'm seeing cancer patients every day. And if I had this cancer, these are the questions that I would ask. So I would highly recommend you find yourself a piece of paper and maybe a pen and write some of these questions down because believe me, these are the most important questions to ask. Now, the first thing I want to go over is lung cancer in general. And just note that lung cancer is divided into two. It's divided into non-small cell lung cancer and small cell lung cancer. So I'm assuming if you're a patient and you're watching this video, you've been told you have small cell lung cancer. So chances are you had a biopsy done. And if you look at your pathology result, it will tell you you have small cell lung cancer. And this represents approximately 13% of all lung cancer cases. Now, if you were told or your pathology result says that you have an adenocarcinoma or a squamous cell carcinoma, then you have a non-small cell lung cancer. And this represents approximately 87% of all lung cancer cases. So the first question to ask is, do you have a small cell lung cancer? Because if you do, then this is the video that you want to watch. But if you have an adenocarcinoma or a squamous cell carcinoma, in other words, a non-small cell lung cancer, then find this video within my channel where I go over everything that I think you need to know about non-small cell lung cancer. All right, so from now on, we are only going to be talking about small cell lung cancer. So just know that the main risk factor is smoking. I mean, I've been an oncologist for about 18 years now, and I have never seen a small cell lung cancer in a patient that did not smoke. I mean, almost everybody was a smoker. Now, the median age is about 71 years of age. Of course, you can also have this cancer if you're younger or older. Now, when you have a biopsy done, in other words, with a needle, they obtain a little piece of tissue and you look at it under the microscope, what your pathologist will see is that you have neuroendocrine features. Again, this is on the pathology result. Also, you may have a stain that's called chromogranin A, so it can stain for chromogranin A, as well as synaptophysin and CD56. So these are things that the pathologist looks at under the microscope to tell you or to differentiate between a non-small cell lung cancer or a small cell lung cancer. And of course, these are the ones that you typically see in a small cell lung cancer. So a question that I would have is, does my biopsy result show features of a neuroendocrine tumor? Okay, these neuroendocrine features, which is typical for a small cell lung cancer. Now, if you're a patient, you do not need to panic. Just look at your pathology result, and if it says you have a small cell lung cancer or a small cell carcinoma, then there you go. You already know you have a small cell lung cancer. It's as easy as that. Now, this is more for healthcare professionals. So if you're a patient, you do not need to know this. So I don't want you to feel discouraged because I'm going to get a little more technical here. So again, this is more for healthcare professionals. Now, there's a family of tumors that are called the neuroendocrine tumors. And the problem is that this is a spectrum of tumors or cancers, if you will. So if you look down here, you have NET, which stands for neuroendocrine tumor. And I want you to listen to that name, neuroendocrine tumor. Notice that the word endocrine is there, okay? Endocrine. And it's because a lot of these tumors can produce hormones. And that's why they call them neuroendocrine tumors. Now, if you look at it under the microscope, I want you to notice that I have carcinoid on one end, and on the other end, I have small cell lung cancer or small cell carcinoma. And the reason for this is that they are all part of the neuroendocrine family. So let's start off on the top here. So if when your pathologist looks at the pathology result, the biopsy, and he sees a neuroendocrine tumor, because those stains that we talked about on the prior slide are there, the synaptophysin, the chromogranin. So in other words, we see that. But the tumor is very well differentiated. In other words, it looks almost benign appearing. I mean, it does not look aggressive looking. They will call it a carcinoid tumor. Now, as that tumor becomes more aggressive appearing under the microscope, then it starts to go down this line here. So it'll become what we call a low-grade neuroendocrine tumor. Okay? If it becomes more aggressive appearing, then it'll be an intermediate grade neuroendocrine tumor. And then as it becomes more aggressive, it will become a high grade neuroendocrine tumor. And then if it becomes very high grade, they will call it a small cell carcinoma. So just a quick recap. If the neuroendocrine tumor is very well differentiated, it's a carcinoid. As it becomes a little more aggressive, it becomes low grade, intermediate grade, high grade, and a small cell carcinoma. Small cell carcinoma being the most aggressive variant of a neuroendocrine tumor. It's as simple as that, okay? So let's move on. Again, patients, you don't need to know that, all right? Now let's talk about the symptoms. And the symptoms really depend on where do you have the cancer. So for example, if it's only located in the lung, then, and it's very early, then chances are you won't have any symptoms. But as the tumor grows, it can cause shortness of breath, it can cause coughing, it can cause chest pain, it can also cause bleeding when you cough, because if that cancer is eroding into a little blood vessel, you can cough up some blood. It's what we call hemoptysis. Also, if it has spread to a bone, like for example, a rib, it can cause bone pain. It can also cause weakness and weight loss the more advanced that cancer becomes. Again, you can have other symptoms, but it really depends where is the cancer located. Now, this can be a little confusing, especially for patients, but you really need to know this. Small cell lung cancers can produce hormones. Remember, they're part of the neuroendocrine tumor family, so they can produce hormones. And sometimes patients with small cell lung cancer can develop these syndromes that are called paraneoplastic syndromes. And it's because their lung cancer is producing hormones. So the lung cancer is giving you symptoms, but these hormones can also give you other symptoms. So the most common of which is what we call SIADH, so it's antidiuretic hormone. So the tumor can produce antidiuretic hormone, and what this does is that it decreases your sodium levels. So you develop what we call hyponatremia. And again, it's not that common. It happens in about 15% of cases. I do see it from time to time. And the most important treatment for all of these paraneoplastic syndromes are you treat the cancer first, because as the cancer improves, the paraneoplastic syndrome improves. In other words, as the cancer shrinks, the amount of hormones that they might be producing also decreases. So besides that, if you have SIADH, okay, that you have inappropriate secretion of antidiuretic hormone or production of antidiuretic hormone, you also want to fluid restrict. In other words, you want to take in less water. This will help increase your sodium level. And there are also some medications we can give you to help increase your sodium. Now, there are other paraneoplastic syndromes. These are much less common. For example, ACTH is another hormone that the tumor can produce. This increases the cortisol levels in your bodies. In other words, it's a steroid, and this can cause what we call Cushing syndrome. So this can result in a lot of fluid retention, what we call a moon face, because your face starts to retain a lot of fluid, so you develop a round face, if you will. This is the medical term that we use. Also, you can develop abnormal hair growth in certain parts of your body, muscle loss, easy bruising, high blood pressure, low potassium levels. So if you notice that, you're retaining a lot of fluids and your face is becoming round in appearance, you're also having some of this abnormal hair growth and your potassium is low, you may have an overproduction of ACTH with your small cell lung cancer. Again, the main treatment is to treat the cancer, but there is an antifungal that's called ketoconazole that if you use it, it can help reduce some of these symptoms. There's another one, very uncommon, that is called parathyroid hormone related peptides. So the parathyroid hormone can increase calcium levels in your body, so you can develop hypercalcemia. Okay, again, the treatment is you treat the cancer and you give medications to decrease your calcium level, namely like bisphosphonates, for example. So if you have small cell lung cancer and you have hypercalcemia, meaning an elevated calcium level, maybe you have this. And you can actually test the blood for all of these hormones, by the way. The other one, the last one, which is the least common, is growth hormone. Again, as the name implies, growth hormone, you start to develop abnormal bone growth. Your organs tend to overgrow, and it will be quite obvious to you. And again, you want to treat the underlying cancer. So the question to ask here, if you have a small cell lung cancer, do you have a paraneoplastic syndrome? Meaning, is your tumor producing either, for example, ADH or ACTH or PTH or GH? Okay, the four that we went over. Thankfully, these are not common, so there's a good chance you do not have one of these. So again, I just wanted to go over this, make sure that this is not overlooked in your case. Now, the workup. So if you have been diagnosed with a lung cancer, any type of lung cancer for that matter, chances are your doctor will perform a complete blood cell count and a CMP. In other words, we want to know what is your white cells, your red cells, your hemoglobin level, also your kidney function, your liver function. Remember, we want to look at your sodium levels because of the paraneoplastic syndromes. We want to look at your calcium level. So these are all things your doctor will look at. Of course, we want to stage you. We want to know how advanced is this cancer. So we can do this either through a CT scan of the chest, abdomen, and pelvis, or a PET scan. And these scans really should be done with contrast. The CT scan should be done with contrast so you can really visualize areas like your liver, for example. Also, small cell lung cancer might travel to your brain. Okay, so this is one of the more common sites that it can spread to. So we also want to perform an MRI or a CT scan of the brain with intravenous contrast. Now, I can tell you an MRI with contrast is superior to a CT scan with contrast. But sometimes patients are either claustrophobic or they have metallic objects in their body and they're not candidates for an MRI. So in that case, we would recommend a CT scan. And we recommend an MRI of the brain or a CT of the brain, especially if you have neurological symptoms. So for example, headaches, blurry vision, you're unsteady, the way you ambulate, you just have unsteadiness. In other words, you have symptoms or signs that maybe you have something going on in your brain. We want to image your brain to make sure we do not miss a metastatic small cell lung cancer to your brain. And obviously a biopsy would be done. Now, if you're watching this, there's a good chance you already had a biopsy, but something that I do want to cover. First of all, there are several ways to obtain a biopsy. Either they can do an endoscopic ultrasound in your lung where they obtain a biopsy that way, or through the outside of your chest wall, they can obtain a needle biopsy. And you obtain a little piece of tissue, and under the microscope, they will tell you what type of cancer you have. Of course, in this case, they would have told you have a small cell lung cancer. So find your pathology result and follow along. Now, the other thing I want to cover is a lot of times patients worry that if they do a biopsy, that biopsy can spread the cancer cells. It's what we call seeding. I want to let you know that the available data that we have suggests that needle biopsies for lung cancer likely do not spread your cancer. And if they do, it's exceedingly rare. So the benefit of obtaining a biopsy far outweighs any potential risk. Okay? So yes, we do biopsy because it's really the main way that we can make sure that you do have a lung cancer, because if you do not, we obviously don't want you to put you through all of these treatments. All right? So, why is it called a small cell carcinoma or a small cell lung cancer? Well, when you look at it under the microscope, they are very small. They're characterized by these small cells, and they are round to oval in shape. So, pretty simple. You look at them under the microscope, they're these small cells, so they called it a small cell carcinoma. There you go, very simple. Now, I do want you to look at this. The first thing that I want to teach you is that small cell lung cancers typically occur in this area of the lung, what we call the central portion of the lung, because this is the outer part of your lung, okay, the outer part, and this is the middle part of your chest, or the center part of your chest. So small cell lung cancers usually grow in this area here, the central portion of your lung. Now, these are your bronchioles here, and this is your trachea. And it's hard to see, but I don't know if you see these little green objects around your trachea and around your bronchioles. These are lymph nodes. And what's important to know about these lymph nodes, and these lymph nodes are little bean-shaped structures that are part of your immune system. The thing with lung cancer, both non-small cell and small cell lung cancer, is that they love to travel to lymph nodes. So in this case, this in yellow, this is the small cell lung cancer. Now this will grow in this area, and ultimately it can start to spread to these lymph nodes. And then after it spreads to these lymph nodes, it will spread to other areas of the body. Once again, the bone, your liver, your brain, and other organs as well. So you want to know this, because when we do a CAT scan or a PET scan, for example, we want to focus on these areas. We want to look at your lungs. We want to look at the center of your chest, namely looking at these lymph nodes. Okay, we want to know if these lymph nodes appear enlarged. Could they have cancer in these lymph nodes? Very important. And we also want to look at the other organs that the cancer typically wants to spread to, okay? Because we want to stage you. We want to know how advanced is this cancer. All right? So with that being said, moving on to the next slide is staging. So as already stated, we obtain these CAT scans, these PET scans, and we want to know how advanced is this cancer. Now, most cancers are staged, usually stages 1, 2, 3, and 4. Stage 1 is the earliest form of cancer. Then as it becomes more advanced, you will go to stage 2, stage 3, and ultimately stage 4 being the most advanced stage, what we call metastatic disease. Now, small cell lung cancer is an exception. We do not stage small cell lung cancer this way. It's actually even easier to stage. And that is, we stage it as either limited stage or extensive stage. Now, limited stage, as the name implies, is that it's limited to one area. And what defines limited stage is basically, can the radiation doctor, in other words, the doctor that gives radiation, can they fit the area that has small cell lung cancer within a radiation port or a radiation field? Okay, so if the answer is yes, the radiation oncologist can fit that tumor within the radiation machine, then you have limited stage small cell lung cancer. Now, if it does not fit in that radiation field, then you have extensive stage small cell lung cancer. So in other words, if you have, for example, disease outside of your lungs, so if it's in the brain, if it's in the liver, if it's in your bone, obviously you have extensive stage. So the question to ask as far as staging is concerned is, what stage are you? Do you have limited stage small cell lung cancer, or do you have extensive stage small cell lung cancer? All right? It's very important because the limited stage or the extensive stage, you need to know this in order to move on to treatment. All right? So the treatment depends on if you have limited stage or extensive stage disease, and you have many options here. So in general, the options are surgery, chemotherapy, radiotherapy or radiation therapy, and immunotherapy. Okay, these are all options, and sometimes we give you a combination of these. All right, so now let's get specific into each one. So let's start off talking about limited stage. So in other words, you went to your radiation doctor and they told you, you know what? It looks that it's confined to an area. I mean, your medical oncologist will tell you as well, because it seems like your cancer is only limited to your lung area, or it's just locally present. Okay, so there they can give you radiation. Now, if you have limited stage disease and it is extremely early, meaning it's extremely limited, okay, you were lucky enough that they found it very, very early, sometimes we can do surgery. And the reason is because historically, small cell lung cancer did not undergo surgery. Most of the times we treated them with chemotherapy and radiation. Now, if you have very early stage small cell lung cancer, you might be a surgery candidate. And that's important to ask. Now, what your doctor wants to make sure is that your lymph nodes, remember we went over on the anatomy slide, your lymph nodes are not involved with cancer. So if your PET scan is clean in that area, meaning your lymph nodes are not involved, or more importantly, if your surgeon can perform lymph node biopsies just to confirm that you do not have cancer in those lymph nodes, you might be a candidate for surgery. And a way they can evaluate these lymph nodes, again, different ways to do a biopsy, is either through a mediastinoscopy. That's very simple camera going through your neck area. It's a small little camera going into your chest wall and obtaining lymph node biopsies, or what they call an EBUS, which is an endobronchial ultrasound, where they'll go in through your nose, into your lungs, and they'll obtain a biopsy that way through the trachea or through the bronchioles. All right? And if your lymph nodes are not involved with cancer, meaning your lymph nodes are negative, meaning negative for cancer, then you might be a surgical candidate, followed by chemotherapy, maybe radiation. Sometimes we'll add radiation, and possible immunotherapy. So this is a scenario that you might go for surgery, chemotherapy, radiation, and immunotherapy. Okay, this is a discussion between you and your doctor. So a very important question I would have is, if you're limited stage, are you very early limited stage? Because if you are, you might be a surgical candidate. Now, if your lymph nodes are involved, or it's limited stage, but it is not extremely early, then chances are you will be given chemotherapy and radiation together. It's what we call concurrent chemo radiation, usually followed by immunotherapy. And again, don't panic. I'm going to go over this in much more detail in the next slide. Remember, we're going to be repetitive here so to make sure you learn this. Now, the last thing I want you to know about limited stage disease is something that they call prophylactic cranial irradiation. Now, remember I told you that small cell lung cancer can travel to your brain. That's an area that we worry about. So if you have limited stage disease in your lung and they treated you, we are still fearful that this small cell lung cancer can appear in your brain. So sometimes we will give you prophylactic radiation, in other words, radiation to try to prevent this cancer from popping up in your brain. Okay, now I can tell you historically we did this much more often in the past, and recently it's sort of falling out of favor, but it is still considered a standard of care. Okay, so a question that you can ask your doctor after you've been treated for your limited stage small cell lung cancer: are you a candidate for prophylactic cranial irradiation? So now let's get into detail about the limited stage. So remember, If you're very early, surgery is an option, but if you're not extremely early, then chances are you will be given chemotherapy and radiation followed by immunotherapy. Now, let's talk about the specific chemotherapy regimen that you will be given. Now, the most common one is a platinum, which you have two options, and those are either cisplatin or carboplatin. So just know they both have risks and benefits. So cisplatin tends to cause a lot of nausea, a lot of vomiting, and it's pretty harsh on your kidneys. So you have to really monitor your kidneys and drink a lot of fluids while you are undergoing cisplatin. And it can also lead to deafness if you use very high doses for a long period of time. So just something to keep in mind. Whereas carboplatin is really adjusted based on kidney function. So carboplatin's main side effects are that it can reduce your blood counts, it can cause anemia, it can decrease your immune system, and it can also cause infusion reactions. Those are the most common ones that we see. So your doctor will choose either cisplatin or carboplatin together with a medication, another chemotherapy agent that's called etoposide. Now, etoposide tends to cause hair loss, and also it can decrease your blood counts. And the way we give it is that it's chemotherapy that's given over 3 days. So on the first day, what we call day 1, you'll receive the platinum, again, either cisplatin or carboplatin, together with etoposide. So that first day, you will get both chemos. Then on the second day and the third day, you will receive etoposide by itself. All right? And then 21 to 28 days later, we will repeat that same regimen. You will get those 3 days of chemotherapy again. And then 21 to 28 days later, you will receive the same chemotherapy regimen. And we are monitoring your blood counts, your kidney function, your liver function to make sure your body is tolerating it. Because if your kidney function is abnormal, or if your liver function is abnormal, or if your immune system is too low, then we might hold chemotherapy and give it maybe another week for your body to recover, and then we will give you the chemotherapy as soon as your body recovers. And now we give you this chemotherapy together with radiation. Now let's talk about radiation here. Radiation is given Mondays through Friday, okay, every day for about 6 weeks. And this can vary a little bit, and sometimes instead of once a day, you can receive it twice a day for 3 weeks, give or take. And this is what we call hyperfractionated radiation. All right, so just a quick recap here. You will get the chemotherapy, the 3 days of chemo, and then 21 to 28 days later, the same chemo. And at the same time, you will be receiving the radiation either every day, Monday through Friday, or twice a day, Monday through Friday. And then after you complete this treatment, they might recommend maintenance immunotherapy. In other words, once you're done with chemo and radiation, they may consider giving you immunotherapy to try to prevent this cancer from coming back. Okay, it's what we call adjuvant therapy. In other words, it's a treatment that we're giving to try to maintain you cancer-free, or try to maintain, or try to prevent rather, this cancer from coming back. And usually we give it every 28 days for up to 2 years. All right? So the recap here. So what you need to know, the questions that I would ask if you have limited stage small cell lung cancer. So again, it's quite simple. Just ask your doctor, do you have small cell lung cancer? If you do, are you limited stage? If the answer is yes, then the questions to ask are, what chemotherapy will I receive? I can tell you a platinum and etoposide is the most common. What radiation therapy will I receive? Will it be once a day for about 6 weeks, or twice a day, what we call hyperfractionated, for about 3 weeks? Also, since you're limited stage, once you're done with all treatment, ask about prophylactic cranial irradiation. Do they think that you're a candidate for that brain radiation to try to prevent that cancer from popping up in your brain? And are you a candidate for immunotherapy? That's it. Those are by far the most important questions to ask if you're limited stage small cell lung cancer. Now, extensive stage, meaning it's a little too advanced, unfortunately, that radiation is no longer an option. But there are times where we still give you radiation. Okay, and I don't want to lose you because it's a common sense decision as far as radiation is concerned. So for extensive stage small cell lung cancer, meaning it's a little more advanced, the standard of care is chemotherapy, considering an immunotherapy, okay? And sometimes we give you radiation. Now, the sometimes radiation is if you have metastatic disease, or for example, if you have a reason to receive radiation. So let's get into detail here. The most common sites of metastasis we already went over were your bone, liver, your brain, and lymph nodes. So let's say you have pain in one area. Let's say the cancer is growing in and it's encroaching into your ribs and you have a lot of pain. We can give you radiation to that area to decrease your pain. Or let's say you're bleeding, okay? The tumor is encroaching in a blood vessel in your lung and you're coughing up blood. We can give you radiation there to burn the tumor, and it usually improves the bleeding, or it stops the bleeding. And actually, I've had several patients with this and it works very well. Let's say you have obstruction. This tumor is growing in your lung and it's obstructing an airway, okay? And a lot of times this can lead to what we call a post-obstructive pneumonia. You can develop repetitive pneumonias because this lung cancer is blocking off an airway. We can give you radiation and that can open up that airway. Another reason which a lot of times we absolutely give radiation is if you have brain metastasis. So if the cancer's gone to your brain, the chances are your doctor will absolutely give you radiation. Or for example, maybe you have cancer in your spine. I mean, we want to treat this as soon as possible so you don't end up paralyzed. So a lot of times they will give you radiation and maybe even a steroid. So these are the indications for radiation. But if you don't have any of these, chances are you will not receive radiation. So the chemotherapy, keeping it simple, once again, it's a platinum, either cisplatin or carboplatin, which we already went over on one of the prior slides, together with etoposide, with immunotherapy. And the most common immunotherapies that we use is either atezolizumab or durvalumab. You can take your pick. They're both excellent. And again, the platinum is given day 1. The etoposide is given for 3 consecutive days. The immunotherapy is also given day 1. And then every 21 days, they will repeat the cycle and they'll give you up to 6 cycles. In other words, on the first day of treatment, you will receive the 2 chemotherapies, either cisplatin or carboplatin together with the etoposide. You will receive the immunotherapy. And then on the next 2 days, you will receive only the etoposide. All right. And it repeats itself every 21 to 28 days. And we will monitor you. Now, once chemotherapy is completed, then we will give you only maintenance immunotherapy. Sometimes we don't give it because there are reasons that you might not be a candidate for immunotherapy. But for the most part, we will give you immunotherapy every 28 days until either your cancer comes back or you do not tolerate the immunotherapy. In other words, you've received so much immunotherapy that it's making you sick. It's making you ill. All right? So very simple. Just a quick recap here. If you're extensive stage, do you have a reason to receive radiation? Pain? Do you have bleeding? Do you have brain mets? If the answer is yes, then radiation is the way to go. If not, they will start you off on chemotherapy and immunotherapy, and they will give you about 6 treatments or cycles of chemotherapy and immunotherapy. And then after that, we will stop chemotherapy. And if you're a candidate for it, we will leave you only on immunotherapy. And I can tell you, most patients tolerate immunotherapy fairly well. All right. So if you have extensive stage small cell lung cancer, the questions to ask is, do you need radiation? Okay. Do you have pain, bleeding? Well, we already covered. What chemotherapy will you receive? Once again, chances are it will be cisplatin or carboplatin together with etoposide plus an immunotherapy if you're a candidate, and then you will remain on maintenance immunotherapy. So obviously ask the question, are you a candidate for immunotherapy? All right. The main reasons you might not be a candidate for immunotherapy is if you have connective tissue disorders, like if you have lupus or scleroderma. In other words, these autoimmune conditions, a lot of times you might not be candidate for immunotherapy. There are others, but those are for the most part the most common. Now, follow-up. So as you're being treated, or once you were treated, your doctor will want to follow you to make sure you're doing well and to kind of make sure this cancer does not come back or does not start to grow. So it's really variable depending on your case. So your doctor may recommend CT scans or a PET scan every 2 to 6 months. It really depends the case. They may also recommend a brain MRI or a CT scan of the brain. This is mainly done if you start to develop neurological symptoms, then an MRI of the brain is the way to go. If you feel well and you do not have neurological symptoms, then chances are they will not perform an imaging test of your brain. But again, this is between you and your doctor. Obviously, they will follow blood tests. They want to make sure your kidneys, your liver, your potassium, your sodium, your calcium, that these all are fine and normal. And as time goes by, in other words, as the first year, the second year, the third year go by, if the cancer does not come back, then we will perform less imaging. Because remember, a CT scan or a PET scan does give off, or it does expose you to a little bit of radiation each time. So we want to try to reduce the amount of imaging tests. Also, a CT scan, the contrast of a CT scan can be somewhat toxic to your kidneys, especially if you have bad kidneys to begin with. Or the contrast for the MRI, which is called gadolinium, also has its known side effects. So again, we want to perform these imaging tests, these pictures, if we really have to. And as time goes by, we can decrease the amount of CT scans, MRI scans, and PET scans that we perform. All right? So, relapse. So what if the cancer comes back? Or, so for example, let's say you're a limited stage, you were given chemotherapy, radiation, and immunotherapy, and unfortunately the cancer came back. Or you were extensive stage, meaning you have advanced disease. We knew we cannot cure you because you have advanced disease, but the tumor now starts to grow again. Then in these cases, we have a lot of options. And that's the good news about it, that we have options to give you. So for example, let's say you were given a platinum, either cisplatin and carboplatin, and etoposide, and the tumor grew back more than 6 months later. So 6 months later, a year later, then we can still give you cisplatin or carboplatin plus etoposide, because it kind of kept you cancer-free for a certain amount of time, okay? It did not come back immediately after treatment. So that would be one option. Another option could be either cisplatin or carboplatin once again, but this time instead of etoposide, we may substitute it with irinotecan. So that's another option. Another option is another chemo called topotecan. Another option is this other medication or other chemotherapy, lurbinectedin or tarlatamab. That's another option. And there are other options that we can give you. So the bottom line here is, if your cancer unfortunately comes back or regrows, just sit down with your doctor. Each one of these have their own side effect profile, their pros, their cons. So just sit down with your doctor and kind of figure out which one of these is the best option for you upon relapse. All right. So with that being said, I told you it's very comprehensive. We covered a lot of information, but this is what you need to know. So if you are a healthcare provider, my goal is to provide an educational video on every single cancer type. Now, I am a practicing physician, so it takes me time because I'm actually working every day, but I will get to it eventually where I will have a video on every single cancer type. And for the patients out there, I wish you the best. And again, if you know this, now you are prepared. And believe me, your doctor will be impressed. And I'll take it a step further. Not only will your doctor be impressed, but a lot of times they will pay more attention to your case because they know that you are on top of your game. You know what's going on. So believe me, it's in your best interest to know all this. So all the best to you.